Everybody. This is actually session 5 of our Dementia Echo program, and we have another lovely guest speaker, Dr. Nancy Isenberg. And she actually is going to continue to contribute to Alaska's dementia-capable care. That will be coming out to you shortly, so those folks in Alaska can register for more sessions with her. So we're looking forward to her presentation today. I'm going to go ahead. This session does give you credit for nursing continuing education. So you have 1.0 contact hours that you can achieve if you stay for the whole session and you complete the evaluation form. So we will not give partial credit and all of that. My disclosures are here. I have some pharmaceutical stock, as well as Dr. Gomi also has some stocks and an honorarium that he has. So all of those ineligible financial relationships have been mitigated, so no worry about that. Announcements. Does anybody else feel free to unmute if you have any announcements? This is your time to speak now or forever hold your peace. Anyone? Going once, going twice. Okay. As you can see, we are on the comprehensive care planning. And so that is just awesome, and we'll continue the series. So I am going to let Nancy take it away.
Thank you so much, Amber, and hi, Reza, and everybody. It's really great to be here with you all. And before I dive in, I do want to take a moment also to talk about the upcoming Alaska Project Echo that Amber mentioned, and to say that we have CME approval. So if that is something that you're also interested in, and the timing will be on Alaska Standard Time as well. And we're launching on January 10th. So thank you for having me here today. I'm a cognitive neurologist and neuropsychiatrist, and I'm also trained in lifestyle medicine. And I'm going to talk about, dementia is a very complex disease that affects not only the individual, but also the family at tremendous cost, a myriad cost. Next slide, please. So the objectives today are that by the end of our brief gathering together in this community, you will have more resources to really leverage the tools and the training to have a greater impact and greater efficiency. So really practice transformation is what we're aspiring towards. And to be able to identify the management goals and your role caring for individuals who are living with dementia and their care partners. And then really to know what the best and most appropriate codes are that really reflect your time, your effort, the complexity, the team setup, and so forth. Next slide, please. Next slide, please. Right, and the codes that we're going to talk about today were really designed by CMS to try to have the time and recognize the care. So what do we want to do? We want to either implement, put dementia prevention science into practice to improve quality of life from a sort of age-friendly perspective. What matters to the patient? What are his or her goals of care? How do we maximize function, functional independence, compensatory mechanisms? How do we boost cognition? Also addressing any mood symptoms, which, as we know, the brain and the mind and the body, we're an embodied being, and the brain and the mind are the same organ. So there's such a tremendous interrelationship between cognition, mood, and behavior. How do we create an environment that is safe for people to thrive, continue to cultivate this social engagement, and then, given that it's COVID, help people to connect with also virtual engagement as well. We want to have social connection and physical distancing for safety, and really living in line with your values, your strengths, your wishes, and relying on procedural memory or habit learning as a compensatory strategy as well. And then really minimize these care transitions, which can be so discombobulating for people living with dementia. So keeping them in the community and well cared for, and reducing these opportunities for failure and enhance these successful outcomes. So next slide, please. So then just, I mentioned age friendly, and I thought it would be good to kind of frame that. Some of you may be familiar with this. This is actually an evidence-based type of care that the IHI, Don Berwick at the Institute for Healthcare Improvement, and a number of others kind of whittled down to these elements. And initially there were 4 elements, and at Providence we've added a 5th, which is malnutrition. And we know, as Hippocrates said, that food is medicine. So the first of the 5 M is, what matters. What matters really impacts your quality of life and your care. What matters to the patient and the family. Know the preferences. Establish an advanced care directive or plan for the future. Identify trusted decision makers. Do a very careful medication scrub and deprescribe when you can, and simplify when you can. Make an assessment at the annual wellness visit for mentation, and then diagnose using HCC codes, and try to optimize functioning, leveraging cognitive reserve and lifelong learning. And then mobility, keeping people up and moving and preventing falls, but addressing sarcopenia risk and other risks. And then, as I said, food is medicine, malnutrition, or the MIND diet, which is the diet that has been studied most in dementia, and we can talk about later, perhaps in the questions. Next, please. So, this is a vast problem. That's why we're all gathering today. And the earlier we identify people with cognitive challenges, the greater the opportunity there is for them to retain their functional independence, and at tremendous cost savings to communities, health systems, families, and so forth. And this is, as I said, the prevalence is rising, with over 7 million people projected for 2025. And as I say, time loss is independence lost. And what we know is that fewer than 1 in 2 cases of people living with dementia are identified in primary care. And unfortunately, and in communities of color, all too often, this is at the moderate to late stages, where we have fewer things to really offer to course correct or boost quality of life. Next, please. So as I just said, there's a large body of work that has indicated the importance of early, timely, and accurate detection. Why? Because we can address these modifiable risk factors, namely cardiometabolic risk, identifying and treating depression. You have improved management of comorbid conditions, of which there are many in the elderly, addressing, as we said, polypharmacy and potential iatrogenic harm, meaning avoiding those unnecessary hospitalizations or those elective surgeries for which the risks outweigh the benefits. And then linking to programs and services in the community, and making sure that the foundational environment is safe and that there's educational resources for that care partner. And as we've been talking about, really what matters and when do we bring in palliative care earlier rather than later as a great symptom management and team support approach. Next slide, please. So, this just is a analysis that demonstrated that over $8 trillion could be saved in medical and long-term care costs if mechanisms for early detection of AD are employed. This is very, very, very important. And we capture those costs because, as we've already said, you can course correct, you can treat untreated sleep apnea, you can get hearing aids, you can get your A1C from 9 to lower, and so forth. So you can really improve, and people can live with mild cognitive impairment quite well for some time, and some of those people will normalize. So on average, and this is Ron Peterson's data, 6 out of 100 will progress from MCI to Alzheimer's disease if their MRI has particular features, namely small hippocampus compared to age-matched controls on a type of post-processing neuroquant software. Then that risk is double, so say 12%. Next slide, please. So we also know that many people with dementia and MCI are hospitalized, and that hospitalization is really, really costly, 2 to 3 times as costly compared to older people who do not have dementia. And people with dementia who are, in the community are at significant risk, as you see on the slide. And we know that that hospitalization is associated with increased risk of delirium, which is preventable in many cases if primary prevention is the best, but also management, which we could talk about. There's increased risk of falls, post-hospital cognitive decline and functional decline, rapid readmission rates, longer length of stay, and loss of independence requiring higher levels of care and care burden, and sometimes death. So next slide, please. And we've seen that in the pandemic, of course. Okay, so moving now to your visit. And I know this is a group that is comprised of some primary care and some people in different milieu. So this now we're seeing the patient in the office, and you want to make sure that you hand all your medications. Some people bring that bag, and you want to make sure that it's both over the counter and prescription, because some people are taking the Tylenol PM that has Benadryl that's making them confused. Then you do your med recon, and of course you're going to give them a printed copy at the after visit summary of all their medications, so they have that with the new dosing regimen. And we want to bring in some, the Alzheimer's disease drugs, the cholinesterase inhibitors and NMDA antagonists. The cholinesterase inhibitors we want to bring in early. They're approved for mild to advanced, but memantine is only approved for moderate to advanced. And look for benefits. There's peripheral cholinergic side effects for the cholinesterase inhibitors that you need to talk about, including GI, diarrhea, some lightheadedness. You can get bradycardia. So you want to have those conversations, and it's a shared decision-making process. Some people may have benefit, others may not. Some people may not tolerate because of side effects. And then thinking about, is there benefit in stopping these medications? And simplify when you can. Simplify and deprescribe at every opportunity. If you can give a medication once a day, go for it. So next slide, please. And then this is just a very helpful resource guide. In the state of Washington, we have a wonderful teaching guide for families. It was developed called the Dementia Road Map, which I literally hand to families at every visit because it's just so helpful. But this is a really great resource as well from the Mayo Clinic. Next slide, please. But yes, rely on program services and resources in your community. So how do we mitigate the impact of Alzheimer's disease? Well, in most cases, it's, low, people present with tip of the tongue dysnomia, rapid forgetting. So the person living with the disease can't change, but the environment can change, and the care partner, in terms of understanding and approaches, de-escalation strategies and so forth, can change. So you kind of think of that triangle, and if the person living with dementia is up here, you have the environment and the care partner kind of holding and supporting and helping that person to stay well for as long as possible. And you can address cardiometabolic risk. We've talked about that, treating the hyperlipidemia. If somebody has had a TIA or a stroke, then you want their LDL to be less than 70. You also, from the perspective of the SPRINT MIND study, and if somebody can tolerate it without dizziness, systolic blood pressure of 120 or less, which may not be appropriate in your 80-year-olds, but might well be appropriate in your 70-year-olds. Really getting that low glycemic diet and MIND diet to control diabetes, exercising 150 minutes of aerobic and strength training, and then staying cognitively and socially engaged. Next slide. This is, I'm sure, a review for you all. I think it's nonetheless important to talk about at every visit. Okay, so here's what I was just saying about the SPRINT MIND study. This is an ongoing study, actually. The preliminary analysis demonstrated that there was a reduction in MCI with tighter control, aggressive blood pressure management, which we're now looking at further. It may not have been powered to demonstrate impact for dementia. Next slide, please. And then, as we said, to really kind of look at what people are taking and to streamline and simplify. So, and use blister packs, or use, sometimes people who are on their own can do quite well with those timer type medi sets as well, that you can leverage technology in some creative ways, and then really reducing the number of drug passes that can really help in terms of errors. to take medications. Most people forget medications. Most people, in terms of adherence, this is all comers, it's like less than 80%. So think about that in the context of lots of medications, being elderly, and maybe having some cognitive challenges. So we want to simplify, and if we're putting somebody on a medicine, we want to have a good justification. Next slide, please. As I just said, I'm not going to go into that. Next slide, please. And then this is sort of the brain. I love that slide. Thank you. So great. The brain health prescription. We want to investigate about alcohol and, fewer than 1 to 2 drinks. Some people, obviously, if you're in recovery, that would be 0 drinks. But if you're not in recovery, fewer than, for women, 1 drink, and for men, 1 to 2. We talked about avoiding anticholinergic medications, and I mentioned the Tylenol PM or other over-the-counter medications that can be inadvertently missed. Doing your stop bang or asking for excessive daytime somnolence or loud snoring to identify sleep apnea, hearing loss, mood symptoms, as we reviewed, and the recommendation around exercise, cognitive engagement. There's a wonderful app called Healthy Minds program that is free and from University of Wisconsin and really focuses on the 4 constituents of well-being, one of which is awareness or concentration, and can help people with MCI really to, I think, strengthen the neural circuitry of their attention. And then, as we said, the Mind Diet or whole food pan predominant, and these recommended guidelines around systolic blood pressure and LDL. Next slide, please, Mahalo. Okay, and we talked about this as well. I think also for transitions, really limiting transitions and understanding that familiarity and structure are really helpful for people living with dementia. So provide an environment where a person can function with minimal failure and maximal thriving. Next slide, please. So what is this 99483 code? Well, it was developed by CMS, as I said, to try to really address and value the time and complexity of the care that's required for people living with cognitive impairment. Next slide. And it's a very high RVU. So people may or may not know, but it's a 3.81 RVU in 2021. So it does require quite a few elements. I will acknowledge that, and we can talk in the discussion about who's using it and how it's worked. And it does require a team setup. And so the things that you're looking at in this, and it can be done every 6 months, and somebody has to have cognitive issues and they have to be with a care partner. So you're going to do a cognitive assessment. You're going to get the history, obviously, around, their ADLs, their activities of living, how are they doing, a functional assessment, are they capable to make decisions? So you have to have a capacity evaluation, as I said, a functional assessment. I use a FAST, but you want to stage the dementia. You could stage it mild, moderate, and advanced, but I'll use a FAST scale. And then the med recon, which you're doing anyway. Some assessment of depression. You can use the PHQ-2. You don't have to use a PHQ-9. And then a safety assessment, including driving, identify POA, care partner, and how is the care partner doing? Because if the care partner is not well, then the person living with cognitive challenges is unwell. And then update and review things like advanced care planning. Goals of care may have shifted within that what matters model of age-friendly healthcare. And then they leave with the annual after visit summary with your care plan that has addressed all of these components of this cognitive assessment and care visit. Next, please. This is the same thing, but in the Alzheimer's Association, there's a great toolkit that you can download. We could probably follow up with that in an email, and that has, it's like 15 pages where it gives you examples of each of these types of assessment tools and the steps to set up this visit. And as I said, in a team with team-based care, a lot of times this can be done, in conjunction with your nurse or with your medical assistant, or in a team, or with your speech and language pathologist, social worker, and so forth. Next slide, please. And then I did say this, that, the reimbursement is quite good here. It may vary slightly based on where you are, but this is a good reimbursement for physicians relative to other codes that are traditionally used in the office. Next slide. Oh, and I think that's it. Well, lovely. Good. I think I ended on time. So thank you. I don't know if we have time for questions or if we're just moving straight on, whatever people would like.
Amber, you're muted.
I saw that Mary Schramke in Hawaii asked if the Washington State Dementia Road Map, is that available via website download? Can somebody stick that in chat?
And then Reza
I did.
and that was
Yeah.
really nice that you popped it in the chat.
Oh, good.
Thank
Good.
you.
I just wasn't keeping up with the chat with everything else. Oh, awesome.
Yes.
That's
That's
great.
great. Thank you.
And there's a lot of great, okay, can you remind me, Nancy, which article? Yes, so the Sprint Mind is the study that looked at aggressive blood pressure management for reducing risk of MCI. And it's Amarenko et al. In the New England Journal for the secondary prevention of stroke for that aggressive LDL of less than 70. So most people who are elderly have vascular and cardiometabolic risks. So the LDL less than 70 is for secondary prevention of stroke. And as we know, cerebrovascular disease contributes not only to vascular dementia risk, but also to neuroinflammation, neurodegeneration, and so forth. So in my elderly patients who've had a TA or a stroke, that's the goal that I recommend based on secondary stroke prevention.
That takes a lot of patience and education, especially with primary care providers. So often we'll have patients that have that history. We know this data exists for more aggressive control. And they'll say, oh, yeah, I'm on lisinopril and I'm on metoprolol, and my blood pressure is usually it's like in the 140s over 90s. And you're like, no, okay, so I actually want it to be even lower. And so often we have to advocate for patients.
Yes. Yeah, and it doesn't necessarily mean bringing in a third blood pressure medication. It maybe means talking to a nutritionist and getting out the salt, or eating less fast food, or walking more, or or having a prolonged exhalation, soft belly breath, which Herb Benson demonstrated long ago can really help with blood pressure control. So yes, and we can continue to, in this community, help folks to do as well as they can. Yeah, totally.
The mind shift because I think historically we've been very accepting of higher blood pressures as we age. And so it's kind of a mindset shift.
Mm-hmm. Well, there was a recent data. I'm just going to cite, so that's a good point. And if, in primary care colleagues in the audience are feeling nervous about this blood pressure recommendation, there was a huge Harvard study that came out in 2020 that I've shared with some folks. And it's looking at, dementia prevention and treatment, and looking at people 80 and above. So when you aggressively treated their blood pressure to less than 120 systolic, there was not an increased association with falls. So that data is there. There was a slightly increased risk in dizziness. So that's why you're going to have that conversation. But, yeah.
Amber, do we have more time for questions now, or?
We can keep coming with the questions, and then also if somebody wants to, we didn't have any case submissions this week, but if somebody has, if this has spurred a thought about medication changes that you're contemplating for one of your patients, that would be awesome.
Before I continue with peppering questions, does anybody from the audience then have anything they want to ask Nancy about? Don't be shy.
I kind of have a question. We at Mountain Pacific, we've been considering for those folks, we've screened our data, and we realized that there's not a ton of providers that are using the cognitive assessment code 99483. Is that correct? And we were wondering, and I'd like your feedback, you can stick it in chat or just speak up, if there would be any interest in having a small work group that works on, step by step implementing this in your primary care practice. So you can think about that and email us or speak now. For those of you that already have care coordination within your clinic, there's ways of expanding that care coordination team to include, work around the cognitive assessment code, because all of that work does not need to be done by the physician. Your support staff can assist quite a bit in creating those care planning and communication with the patients, et cetera.
I'm curious, does anybody use it? And if so, could somebody from the community share what their experience has been and how it's gone for them? Or maybe just put in the chat if is it new that you've heard of it, or like, is this a new code?
Or even if you've looked at it, but then you kind of like, oh, that's just too much work. Is there a component that you're most interested in implementing? Because, everything within a system, it takes baby steps and a process to get to the end, but you got to take that first step. So would love to hear any first steps that people have already started within their practice and they need the next little oomph. You guys are a shy group. How about from Nancy or Reza? Do you have any basic some
Pearls?
Pearls of
Yeah, I mean, so I'll answer. I mean, I'm very, very committed to practice transformation, because I fundamentally believe that this visit type creates the sort of the structure to really provide that comprehensive, complex care that's needed. And so some of the ways that we've made this work, and I have experience in collaborating in primary care to implement this at other systems, is, teaming it up. So I said, you got to have the tools, the training, the team to transform the practice. And as you said, Amber, and I absolutely agree that it's not one more thing on the shoulders of that PCP. It's in the team. And so identifying who that team is and then getting that training. And then the other piece that's really critical is the template. Because you don't want to be tight, so you got to have your efficiency through Epic or whatever EHR you're using, so that when you're doing that visit, you are prompted to hit those components, or half the note is already completed by your team member who's done the setup or the assessments, all of those different, neuropsychiatric and cognitive assessments, functional assessments, and so forth, as part of the cognitive vital sign and other vital signs for that visit. So the Epic or EHR setup, the team, the tools, the training, the template. And it does, I agree, it looks like it's a lot. I mean, I totally see that it looks like it's a lot, and it is a lot. It takes, it's on average, it's not the 20 minutes of the visit, it's like 40-ish to 50 minutes, but it's not all your time. Yeah. Reza, do you have anything you want to say about that?
Yeah, no, I completely agree. I mean, I think having this separate visit type really makes a big difference, because when you're trying to squeeze in this kind of thing into like an annual wellness visit or just like a normal, 20-minute follow-up, it's just so hard. I understand that can be challenging workflow wise, but that's one thing I've been insistent about. And so when I see patients, very often, with the whole family, caretakers, and et cetera, the magnitude of impact is amazing every time. It always amazes me how much of a difference it makes. And really, regardless of what stage a patient is in, just saw another classic example, someone who has been in and out of a psych unit in Montana, has had multiple interactions with healthcare facilities, and just by really doing pretty poorly, was on an amazingly long medication list, just so many kind of easy, kind of low-hanging fruit to touch on. started making changes, feeling better, right away. And what I love about and what Nancy alluded to earlier is the non-medication interventions are also amazingly, when you look at behavioral interventions, this gives you the space to have that discussion. Like, oh, okay, Mr. Smith, he gets upset when I approach him in the evenings to help him get ready for bed. And you can dissect that a little bit, because rather than saying, oh, he just swats my hand away, I get angry, and let's give him a medication, which is an option. But almost always you can find, if you spend a few minutes, wait a second, he's being triggered because of all these normal reasons, like someone is approaching him and trying to take his pants off, or something, right? All these things. And then you can kind of do a behavioral intervention, restructure it, turn the light on, change the context, all kinds of stuff. And for repetitive, really intense behavior, right? You can set up rewards differently. You can just shower with praise when the appropriate behavior is happening, and focus less on punishment. Those things, I think we forget, and it can be hard to adjust because people, when they're getting older, we're like, oh, I don't want to treat them like a kid, but really some of those same interventions work really well. And so that's kind of like a long tangent but having that visit, having that time allows you to have these conversations and has amazing results. We see those over and over again.
Well, and also, I mean, I think that communication with the caregiver within the family unit, if you're in a primary care setting, or, those conversations that you can have within a nursing home with the CNA staff to really, share examples that work, because patients change over time too. So sometimes you need to up your game a little bit and really think about the cause of some of those behaviors. We certainly want to support people in their home setting, wherever it may be.
And then, oh, sorry, no, I saw somebody put the Lancet article, the 2020 article in the chat, and that's a terrific teaching tool. It's a great article. 40% of dementia cases are preventable over a lifespan. And so you may be seeing folks in your office for the annual wellness visit who don't yet have, maybe they have subjective cognitive concerns and diabetes, and there are opportunities. And so thanks for putting that in the chat, and the graphics are super helpful, I agree. And then I popped in there that Healthy Minds program, because it's something that people can use and they can download on their tablet or their phone. And it's a really good way in our 21st distractible kind of world to really cultivate that neural circuitry of attention, which is key in order for us to encode new information or to remember, basically.
And then I was going to ask, so Nancy, in your clinic, in your experience, have you typically been implementing, have you had success in terms of building the 99483, and do you just sort of make sure your you built your own template and kind of have your own documentation to capture those pieces?
Yes. Yeah, I use it. I basically use it all the time. I use it all the time. And I mean, I'm a cognitive neurologist, so I acknowledge that it's a different context. And at the same time, it works very, very well with the template and the tools that we've created. And as I said, we have people who use this in different systems with the template, and we're building it out, hopefully within Providence more broadly as well. And then the other thing I was going to say in terms of the visit is, and this is a different, completely different topic, but what I found really helpful regarding these modifiable risk factors is to leverage the shared medical appointment or group visits with folks with mild cognitive impairment or early dementia, so that we can meet in a group where we're talking about the same thing. We have more time to be with one another. There's group support and accountability, and people can, through motivational interviewing and other behavior change science, we can support people to, this is, yeah, thanks, Risa, and, to kind of, to address those risks, which makes a difference. Sorry.
In that shared group, in that group
Yeah.
setting, do you include both the patients and their caregivers together with multiple families then?
Yes, yeah, so just to be clear, and thank you for that clarification question. These, because we're in the pandemic, these are virtual shared medical appointments. So it's like this, but people have their cameras on, and which I invite you all to do. And it's a 90-minute visit with me, and we do a grounding practice to kind of come into that moment and focus our attention rather than just kind of being distracted. And then we have a little didactic where I have teaching, and then people leave with a SMART goal pertaining to one of their health behavior targets. And then people check in. Sometimes people text one another. They get like a motivation buddy, and they'll text each other between sessions and how's it going? How's your walking? Or, did you sit today? Or those types of things. And it can be really helpful. And sometimes people will share when they come back, I wasn't feeling very motivated. And then I got my text. And these are true anecdotes. I mean, this is not a study, but they're true around these group visits. And there is a standard waiver that you can use. I'm boarded in lifestyle medicine, and lifestyle medicine has that waiver. And I actually just have it in my template. So like I tell in my template, when it's a virtual visit, you probably all have that kind of virtual visit where they consent. And then in addition to the template for the shared medical appointment, they just consent to have a visit with observers. So it's just part of the note.
The other community resource that is super helpful is the area agencies on aging. And they often have support groups for caregivers as well as patients themselves as well. And that's just another community resource. If you don't have that capability of implementing something within your individual practice, whether it be because of COVID or because of just space constraints or other things, make sure that you reach out to your area agency on aging, and see what they have available, because they might surprise you. I know in Wyoming, we've worked a lot with the Wyoming Geriatric Education Center, and they have a great support system that also does some of those SMART goals and, sharing of tricks and tips and tricks. Super helpful. Awesome. Anybody else have other case examples that they would like to share? How about for the providers? Is there anyone that, kind of has another story off the top of their head about how just getting the family involved in a specific plan of care has reduced some of those perhaps negative behaviors or other issues that were cropping up to keep them at home, independent as long as possible? You guys are a quiet group.
Anybody want to share something that's going really well? I'm just curious because I know you're out there doing the good work. So anything that surprised you or went well, you can put it in the chat if you don't want to unmute or take away your video, but.
Hey, what do you guys think? Just a note about case submissions. Sometimes the case submission form that I attach to our emails may look a little daunting. You don't have to necessarily worry about like having every little speck of evidence on that form. it's much more important that you are able just to come on and talk about your patient, talk about your goals and what your concerns are. And again, the point of all of these echo sessions is an all teach, all learn. So even our expert panelists today, our expert speakers, they continually learn every day. And it's through this sharing that we're actually able to improve our practice over time. So we do want you to submit cases. They don't have to be overly complex. If you just have a patient that perhaps has been in and out of the ER for other, maybe what you consider non-dementia specific reasons, that does impact them as an entire patient. So feel free to submit those cases, and because a lot of what we do within dementia care is care coordination with other specialists as well. You might be in a primary care setting and want to refer to, you know, one of our neurologists here that we have, our cognitive psychiatric facilities and things like that. So we have Dr. Gomi and Dr. Isenberg and other folks on the call that can really up our game. Does that spur anybody else's conversation, or should we vote to end a little bit early? Anybody? Dr. Gomi, you give it you make the final call here.
You know me. I mean, I can just keep talking. No, it's okay to wrap up. And yeah, we've been trying to brainstorm how to encourage the audience to participate more with these sessions, because, you know, it's inherent to the echo model is obviously participation from the audience. So in the world of Zoom now, it's definitely been, I understand it's more challenging, but perhaps we can play with Amber, reaching out to some folks and like almost maybe just assigning cases or something beforehand. Maybe that's just something proactively.
Yeah, that might be an idea. The other thing that is sometimes often helpful, I know, again, in the Zoom environment, often we're locked in our rooms alone, and COVID hasn't helped that at all. But even if you have a coworker that you work with, I think just hearing and having the conversation between the two of you, you know, you might think of particular patients and that you could tag team that case presentation so that the burden isn't on just one person. If you feel shy or camera shy or whatever, you know, having somebody to share that experience with is helpful.
Yeah, well, we can huddle after this, and we'll elicit some cases for next time. But I would just big thank you for Nancy taking time out of her day to talk to us here. Nancy's just runs an amazing program at Swedish, and, you know, known about her work for a number of years now, and so yeah, really grateful to have you with us today.
Thank you again for having me. I really appreciate it, and best of luck, everybody. Happy hauls. Thank
Awesome.
you.
Yeah, we'll keep an eye out for your Alaska echo coming up soon.
Great.
Sounds good. Thank you.
Okay.
Bye bye, everybody.
Bye-bye.